Welcome to the Psychology Talk Podcast. I'm your host, Dr. Scott Hoy. The Psychology Talk Podcast is a unique conversation with experts in the field of mental health from around the globe. Topics include hypnosis and mind-body treatments, ethics and cultural diversity, psychotherapy and psychiatry, emerging treatment modalities, and much, much more. While you're listening, please give us a like and subscribe to the show. It helps us to continue to provide excellent programming. And now, here is the episode. Hello and welcome to the Psychology Talk Podcast. Today my guest is Dr. Stephen Whiteside. Dr. Whiteside is a board-certified clinical psychologist, professor of psychology in the Mayo Clinic College of Medicine and Science, and director of the Pediatric Anxiety Disorders Program at Mayo Clinic in Rochester, Minnesota. He received a BA in psychology from Northwestern University, roundabout here in Evanston in Chicago, and a PhD in clinical psychology from the University of Kentucky. His research focuses on improving access to evidence-based care for pediatric anxiety disorders and obsessive-compulsive disorder through the development of effective and efficient treatments facilitated by technology. He's written several books, some of them including Exposure Therapy for Child and Adolescent Anxiety and OCD, Exposure Therapy for Anxiety Principles and Practice, which is in its second edition, and the Mayo Clinic Anxiety Coach, a parent's guide to treating childhood anxiety and OCD, which is what he will mainly be discussing today on the show. Dr. Whiteside, welcome to the Psychology Talk Podcast.
Oh, thank you so much for having me. I'm excited to be here.
Well, excellent. Well, thank you for taking the time out of your busy schedule to do this. What we kind of like to do sometimes is open up the floor and you can kind of go a little bit further into who you are, how you got into this work you're doing, and kind of let people know you as a person.
That would be great. I'm a child psychologist, and I've been working at Mayo Clinic in Minnesota since 2001. And I specialize and focus on working with kids with anxiety disorders and obsessive compulsive disorder. The way I became a psychologist is not exciting whatsoever. I was in college at Northwestern there in Evanston, and everyone was becoming physicians and lawyers and engineers, and none of those really seemed interesting to me. And both my parents are clinical psychologists, so I was like, they seem to have a good life. They like their job. They supported my sister and I well, so I seemed to have an aptitude for it. So I went towards psychology, and that's how I ended up where I am now. So
sort of a family trade, as it were.
Yeah.
Okay.
Yeah.
Did you pick up any ideas or tools for the trade for them? Are they working in academic settings, clinical settings, private practice?
So my dad was in the counseling services at the University of Michigan.
Okay. Yeah. I'm a former Michiganian or Michigander, as they say. Yeah. So I'm from there. So yeah. And I lived in Ann Arbor for several years. Very good. Yeah.
And then my mom was in private practice and focused on working with families and divorce mediation. And so my mother would say yes, that they did have an influence on me. Our approach to child anxiety is very much working with kids and their parents together. And I think my mom would take credit for that family focus.
I think there's something to that, because as I was reading through the book and getting kind of preparing, it always, when I talk to people who work with children primarily, having worked with some children in private practice and group practice, it's always a chore to get the parents on board with the treatment team. Sometimes. I mean, you can kind of weed people out, but oftentimes it seems like they're dropping kids off to get them fixed, which is sad. It's sad for the parents. It's sad for us as the clinicians to be given that task, and it's sad for the children ultimately, right? So it's kind of a systemic thing. But it seems like your model for that you developed at Mayo Clinic is really about working with the family and teaching them how to help their children.
Yeah, yes, that's exactly right. And there are a number of sort of reasons behind that. But the main one is, we just all do better when we're working together. And there's no reason to handle anxiety or other mental health challenges on your own. It's all very, anxiety is very normal and common, and problems with anxiety is one of the most frequent mental health problems. So we want to remove that stigma and that sense that you have to deal with it on your own. And so we work with kids and their parents together. We work in groups. And a part of it also is it's hard, facing your fears, making changes to any behavior that you do, doing something differently is hard. And we think that all kids will be more successful if they have someone at home to coach them through it. And with kids and teens, that person is most often parents. So we work with kids and parents together. So everyone's on the same page is this is what is keeping the problem going. This is what we have to do. And we'll make a plan and we'll follow through together.
Excellent. Well, yeah. I mean, it totally resonated with me when I was looking through the book. Um, Maybe you can help to differentiate for people in the audience who aren't professionals, or more clearly delineate for some professionals who don't work in anxiety or OCD, what those two things are, what the symptoms are, and what the difference is between those two disorders and just regular nerves or rumination.
Yeah, that is a great question. I love that question because that's where we start in the book. The first section is what is an anxiety disorder and OCD, because understanding that sets us up for how we do treatment. Because understanding what an anxiety disorder is, kind of what the fundamental challenge is, leads to why we do treatment through exposure. So the definition we use of an anxiety disorder is when kids feel more nervous, worried, or afraid of something than we would expect them to.
Mm-hmm.
And I should mention, we lump OCD in with anxiety disorders. It's no longer officially an anxiety disorder. And sometimes OCD doesn't involve fear and worry just as much as disgust or not just right feeling, but we sort of lump them all together because we treat them the same.
Mm.
So the first thing we want to distinguish anxiety disorders from is stress. So an anxiety disorder is when you're feeling more nervous and worried than we would expect you to, as opposed to stress is you're in a bad situation. Kids are bullying you, or you're failing a class, or there's a lot of fighting and anger at home. Something stressful is happening in life, and you're anxious and nervous about it, but so would any other kid, because that's a stressful situation.
Mm-hmm.
We treat that much differently. In those situations, we try to help solve the problem, maybe help them avoid some of the more difficult areas. Whereas an anxiety disorder, everything's going reasonably fine. And life is never perfect, but no one's bullying them. Everyone's generally nice to them, but they're still very shy. They're getting good grades, but they're still worried that they might fail, even though they never have. They're worried parents will get divorced or the house will burn down, even though things are stable at home. In that case, the problem is over anxiety and worry and fear when their situation doesn't warrant it.
Mm-hmm.
When that's the problem, that leads us to treat it with exposure. And the other difference between like what you alluded to and what I mentioned before is everyone is worried and nervous. And that's anxiety is a very appropriate, necessary feeling. It helps us prepare for things. If we're worried about doing well on tests, it helps us study, helps us look both ways before we cross the street, put our seatbelt on. And also, feeling too nervous or worried at times is also normal. Sometimes we're irrationally anxious and nervous. We have a fear of the dark or heights. But as long as it doesn't happen too often, doesn't get in the way, doesn't make our life more difficult, then it's not a problem we have to work on. It's when that fear and worry is too much for the situation and makes our lives difficult. That's when we call it a problem and we decide together to work on it.
Okay. Wow. Okay. Um, how does it differentiate? Like, I think the book kind of does a really good job explaining this, but maybe you can unpack that for the audience. The difference in anxiety across the ages from like childhood to adolescent. How do they manifest?
Yeah. Well, one answer is that pretty much most anxiety disorders can occur at any age. And the main anxiety disorders are generalized anxiety disorder, which is just worrying about lots of different topics frequently to the point that it causes physical and emotional distress. Social anxiety disorder, feeling more nervous and worried about being judged or uh, having embarrassing situations happen, interacting with others. Separation anxiety, being nervous about being away from parents or other caretakers. Those are the main ones. And then obsessive compulsive disorder, having intrusive thoughts about things being wrong or unpleasant thoughts or being contaminated with germs and having to do something over and over again to feel better. Check, count, wash your hands.
Hmm.
Other anxiety disorders, including having panic attacks for no reason, being afraid of being in crowded places, which is agoraphobia, or specific phobias. And so in younger kids, we're more likely to see separation anxiety disorder, like nervousness about being away from parents, or specific phobias of the dark. Um, Once kids start to get school age, social anxiety starts to occur more because friendships and peers become more important in their lives. It's just developmentally appropriately than parents and family. And they start worrying more about what other people think about them and if they're doing things right. And then
Hmm.
as kids get to be older, teenagers, they start to worry more about the future, and generalized anxiety disorder becomes more frequent.
Okay. Okay. And so is the approach different? Like basically, I think what you do is mostly exposure therapy with people, right? It's not, and it's kind of hard to get deep insights from teenagers or children. So I guess insight therapy is not quite what you're looking to do for buy-in or whatnot. But um, how does the exposure therapy work in child and adolescent treatment for anxiety and OCD?
Yeah. So, okay, so the basic treatment for anxiety, like you described, was exposure therapy, which basically means helping kids face their fears over and over again, small steps at a time, so that they can learn through their own experience that what they're afraid of is unlikely to happen, even if things don't go perfectly, that they can handle it, and that their anxiety tends to go down and go away, even if they stay in a situation and don't avoid.
Hmm.
So again, that kind of comes back to our understanding what an anxiety disorder is when kids are overly afraid of something, or overly worried about something. And so we can't talk them out of it. Their parents can't talk them out of them. If they could, they would never come and see us. We wouldn't have a job. So our job is to help give kids repeated experience that what they're afraid of is not as bad as their anxiety tells them.
And okay, so for instance, in exposure therapy, for those of you who don't know, typically you start with a subjective unit of distress, like hierarchy, and obviously you can do that a little bit more intellectually with an adult or a teenager. But how do you do that with an anxious child, for instance?
Yeah. Yeah. So the first step, as you mentioned, is coming up with a list, a fear ladder or fear hierarchy of items that they're going to do exposures to. I always like to use a fear of dogs, uh, partly because I was afraid of dogs. I love dogs. We have a dog. When I was a kid, I was afraid of dogs. And it's just so straightforward. It's easy to talk about and picture someone being afraid of a dog and how you work on it. So a fear ladder for a fear of dogs might begin with watching videos of dogs barking, kind of makes you a little uncomfortable, but not too anxious, and then standing outside the room while someone handles a dog, and then gradually getting closer and petting it, and then walking it, and then doing the same thing with a bigger dog or a younger dog or a dog that's less well trained or barks louder, and then doing exposures where you pet dogs out in public or go to a dog park and be around dogs. So fear ladder is a list of activities where you are specifically doing things that make you nervous to challenge your anxiety.
Hmm.
And then so trying to put that in order, sometimes it's pretty straightforward, but in general, we want to try to start with easier things and work up to harder things, just because that's what most people are up for. And we like to use numbers to rate how anxious things make people, either from zero. We often use 0 to 10 with kids just because it's a little bit more manageable than 0 to 100. So subjective units of distress.
Hmm.
And so we have stopped having them rate each of the items at the beginning on a SUDS rating to put them in
Hmm.
order because, as you allude to, it's just too difficult. And they can generally put them in order for easier to harder without putting that rating on them. And in the end, life never goes as structured as you think it's going to. So you kind of just end up jumping around and skipping things or adding things. So we put less effort and time into putting together the fear ladder just right because we know that we're probably not going to follow it that closely anyways.
Okay. Okay. Gotcha. Do you tend to utilize the child's own language when they're describing things, which is probably a good thing to do with any patient, but yeah.
Yeah, we try very hard just to use very plain language. And that's one of the nice things about working in anxiety is, we have lots of psychological terms, but you really don't need them. You can communicate most of these concepts, facing your fears, in pretty straightforward language. That being said, we do use the word exposure, which is not a very intuitive word for most people. But after we repeat it over and over again, it's fun to hear that kids and their parents talking about exposures after a few sessions of having done it. They get that lingo down pretty clearly, pretty quickly.
Okay. And you do kind of use the same format with adolescents, but probably pulling out that Likert scale, the 0 to 10 or 0 to 100.
Yeah, we definitely use the rating scale 0 to 10 when we are doing exposures for everybody, for kids and for teenagers. So we have them rate how nervous they are that their fear is going to come true. How you're about to pet the neighbor's dog. How nervous are you that it's going to bite you? 0, not at all. 10, terrified. They give us a rating. And then as they're petting the dog, we ask them, regularly, how nervous are you now? And we use that scale for a couple of reasons. One, just putting a number to your anxiety just by itself makes it more manageable, rather than I'm anxious, it's always terrible. Well, I'm pretty anxious, but it's only a 6. It's not a 10. It's been higher before. I feel a little bit more confident already that I can handle this.
Mm-hmm.
And also, when your feelings change gradually, it's hard to really notice that. So having the scale in front of you where, the graph is at a 5 and it was at a 6 before. So things are going in the right direction. I'm feeling better.
Yeah, kind of externalizing stuff so you can not have it in your head jumbling things up. Yeah. Yeah. Okay. So kind of categorizing it, making it more manageable, rather, raising awareness, conscious awareness of it. Yeah. A big chunk of
Yes.
it. Yeah.
Yeah.
Sounds like it. Well, what about OCD? How does OCD, first of all, like how is it difficult to accurately diagnose OCD in children and adolescents? It can be a little bit tricky in adults, but like, how does that manifest with the work you're doing?
So OCD is where we began our program. In Rochester, we have a 5-day intensive treatment program
Mm-hmm.
where kids who don't live close to Mayo Clinic and aren't able to find good exposure therapy close to home come and stay in Rochester for the week. And we have 9 appointments over 5 days, one on Monday where we learn, make a plan, and then 2 a day, Tuesday through Friday, where we begin with easier exposures and hopefully work our way up to the most challenging exposures. And we began that program working with kids and their parents when the kids have obsessive compulsive disorder, and began working with them individually. So that's where a lot of and that was part of the reason we started working specifically with kids and parents together, because we were only with them for 5 days, and then we expected them to go home and continue the work that we had started, and it seemed pretty unrealistic to expect a child or a teenager to continue to plan and do exposures on their own. So from the beginning, we started enlisting parents to teach them to be exposure coaches so that the family could continue after they went home.
Mm-hmm.
And so OCD is partly challenging because it's very heterogeneous. There are lots of different flavors of OCD. There's straightforward anxiety-based OCD. If I touch these germs, I'm afraid I will get sick and die, so I have to wash my hands.
Mm-hmm.
And then there's OCD that doesn't seem to really have anxiety at all. If I touch these germs, it'll just be so gross, I can't handle it. I'm not nervous, I'm just disgusted, so I have to wash my hands. And if I touch something, I have to touch that with the other hand. Some people are afraid something bad will happen if they don't fix it. Other people are like, it doesn't feel right, and I just have to do it to feel better. So that presents challenges because there's lots of different presentations.
Mm-hmm.
And then, so especially with younger kids, one of the main features of OCD is like insight that I know this doesn't make any sense. I know I'm probably not going to get sick, but it's just really scary. And to be on the safe side, I might as well wash. And that's the quickest way to feel better. And might as well wash so I don't get sick. But I know in the back of my head, it's probably not going to happen. Although, of course, there can be OCD with limited insight. But with kids, especially younger ones, it's hard for them to say that. It's if you ask them, well, do you really think you're going to get sick? Yes.
Mm-hmm.
Do you want to wash your hands? Yeah, I want to, a compulsion is something you feel like you have to do, feel compelled to do so that something bad doesn't happen. And with kids, it's harder for them to articulate that.
Okay. And you kind of backtracking here a little bit.
Yeah.
You're mentioning obsessions and compulsions. So maybe a brief description of what it is to have OCD. Like what are the symptoms?
Oh yeah, great. No, thank you for pointing that out. OCD, obsessive compulsive disorder, has two main portions. One is obsessive thoughts, and those are obsessions, which are thoughts, urges, impulses that things are not right, that you need to do something. So the most common is fear of germs. So if I touch a public surface, I have this feeling that or this thought, this worry, I'm going to get sick and die, or that this is really disgusting. Uh, or some people have the thought, if I walk through a doorway while I'm thinking about cancer, that means I'm going to get cancer, and I have got this really intrusive thought that something bad's going to happen to me or someone else. That's the obsession piece. And then the compulsion is a repetitive behavior done to relieve that. So I've touched the doorknob. I feel very sick. I'm sorry, very nervous. I'm going to get sick. So I wash my hands over and over again and thoroughly to make sure that I have no chance of getting sick. Or I walk back through the doorway over and over again with a good thought of health. So to counteract that negative thought. Or I check things over and over again to make sure I haven't left on a light or left something plugged in. And it's that repetitive compulsive behavior makes people feel better, but they're stuck in this cycle that the only way to relieve the distress from the compulsion is to do the ritual, and then the compulsions happen more and more, so they do the ritual more and more, and it takes up more and more time and leads to chapped, bleeding, red hands, and that's when it becomes a disorder.
Yeah. Okay. And like you said before, even a child will understand it doesn't make sense.
Most of the time, yeah.
Yeah.
Especially well, people are different, and there's a wide range, but I would say the vast majority of the time, kids, regardless of how well they can articulate, realize they don't want to be washing their hands or checking things or having these worries, and understand they may not be excited about it, but understand that if I do this treatment, if I face my fears and I don't do the rituals, they can understand how they will eventually start feeling better.
Okay. Yeah. Okay. I mean, it's a A plus B equals C kind of situation. Yeah. It's
Yeah.
logical, but not rational. It's not
Yeah.
rational logic. Yeah.
Yeah, no, no, that's a great way to put it. I've often thought that, like I've been doing this for a long time, so I hear about it a lot, and through like writing books and teaching people and explaining things, you think about it a lot. You think about OCD a lot. I think about anxiety a lot. And so I've gone over these things a lot in my head. And so sometimes when talking, a family who OCD is new to them and they're coming in with their child and like, it just doesn't make any sense. Why are they doing these things? They're washing their hands, but they don't straighten their room. And like, for me, it's just so clear because it's logical. This is what they're afraid of, this, not that. And when they're afraid, they do this and they don't do that. And it just makes complete logical sense. Although, as you pointed out, it's not rational at all because there's no danger from germs from door handles. And that's not more dangerous than having dirty dishes in your room. But yeah, it's very logical, but not rational. I like that description.
It seems to me that evolutionary psychology could probably explain a lot of where it comes from.
Yeah, a lot of the most common fears in general, but also sources of distress and OCD are things that are very important to survival. So avoiding gross, disgusting things that might be contaminated or have germs that would make you sick. Um,
Hmm. Hmm.
Lots of OCD symptoms are around violent or sexual behavior, behaviors that are very instincts and behaviors that are very fundamental to the survival of us as a species.
Yeah. Yeah, exactly. So they make sense. They're right. They're logical, but they're not rational.
Yeah.
Yeah.
Mhm.
Yeah. Um, Real quickly, kind of going back to the book a little bit, we talked a little bit about the model of coaching parents in this process. What is the what does the homework look like? And then we'll step back into the idea of the book. Uh, what does the homework look like for both the parents and the child or the adolescent?
Yeah. So the homework is primarily exposures.
Mhm.
The idea of our treatment for anxiety and OCD is that the most important activity to be doing
Mhm.
is breaking the cycle of avoidance, either avoiding by not going to a social activity or running away from a dog or clinging to parents, or washing one's hands repeatedly or doing other rituals, because that avoidance stops you from learning that your anxiety or OCD is lying to you. So the number one thing we can do is do little experiments where we face our fears, break OCD's rules, and don't do any avoidance or rituals and learn that things turn out okay. So that's where we need to spend the most of our time. So we spend all our time in session doing exposures, and we ask kids and parents to work together to plan, do, and learn from an exposure uh, between appointments. So we go back and forth about how many times we specifically, and we would love them to do it every day, but we're all busy. So we try to say, try to do 3 planned exposures where you're taking out a piece of paper and you're recording it and you're specifically doing something that makes you uncomfortable as an exposure and sticking with it repetitively until you learn that it's not so bad. And that is the main homework that we ask them to do.
Okay. Um, and so how does the book present that to an interested parent? Like, how does the book's format kind of parallel that?
Okay, so the book is in 3 sections, and the first section is about what an anxiety disorder is, and we approach that in 2 different ways. One is through categories, labels, descriptions. So we use the DSM, the Diagnostic Manual for Psychiatric Disorders, that describes the anxiety disorders I went through before: generalized anxiety disorder, social phobia, etc. That's a really helpful way to look at things, because we as people, we like categories. We like to label things. That's how we make sense of the world. And using DSM to put a diagnostic label is helpful. But our treatment is mostly on understanding how the symptoms work. What makes you nervous? How do you respond? And then what happens afterwards that keeps this behavior going? So the second way we look at anxiety disorders and OCD is through the avoidance cycle. What sets off your fears? What do you expect to happen that makes a safe situation frightening? How do you avoid that stops you from learning through your own experience? It's not so bad. And understanding that avoiding and doing rituals makes you feel much better, which makes you most likely to do it again, and makes the cycle go around faster and faster and get worse. And then we talk about, well, if we're not sure if this is an anxiety disorder, or if we are, we also want to make sure that there aren't other things that maybe look like an anxiety disorder or would complicate working on an anxiety disorder. So we go over some other frequent comorbidities like depression or behavior problems or difficulties with eating or difficulties with social communication, autism spectrum features. So that first section is really focused on helping parents understand, is what my child experiencing best described as an anxiety disorder? And is there anything else that describes it better or needs to be addressed before we work on the anxiety?
So the differentials, got it. Yeah. Okay.
Yep. All right. And then, so based on that, so if a parent feels pretty comfortable that, I think anxiety disorder or OCD best describes my child's experience. And the second section of the book is explaining how we treat that through exposure therapy. And we start off with a little bit of history about where exposure therapy comes from. I want to make it clear this is not something that I made up, something that's been around much longer than I have. There's a lot of clinical use. There's a lot of research documenting how it's effective, and talk a little bit about the theories of how exposure works and why facing your fears helps break that cycle and helps you learn through your own experience.
Okay.
And so we start general, and then we just get more and more specific, and then we talk about the different types of exposures. And because you can do exposures to things out there in the world, like petting dogs, or sometimes what makes you anxious are intrusive thoughts or worries. So we have to do exposures to the thoughts themselves. And sometimes, like with panic disorder, what sets off your anxiety are physical feelings, and we have to do exposure to those feelings. So we talk about different types of exposures, planned exposures versus kind of doing them in the moment. And we just keep getting more specific. Like, here are the specific steps for setting up, doing, and learning from exposure and staying motivated. And then we end that section with a sort of general timeline. This is kind of how treatment for anxiety works in our clinic, kind of over the weeks and months, to give you a general sense of kind of what to expect when you're working on it.
Okay.
And then the third section is kind of putting those 2 pieces together. So we've got we have a chapter on each anxiety disorder: social anxiety disorder, OCD, generalized anxiety disorder, and it walks through the steps that we present in the second section of how you set up, do, and learn from exposures for each of the different anxiety disorders.
Hmm.
And the overall goal is that hopefully some families are experiencing the kind of the beginning of an anxiety disorder or a mild anxiety disorder, and just reading this is enough to help them just sort of make a natural shift to facing of fears and stopping avoiding, or they're able to use that to kind of actually do some of this on their own in a structured manner.
Hmm.
Probably maybe more reasonable is that it helps people learn that, okay, this is what an anxiety disorder is. I now feel like I understand it. I have a sense of what I need to look for treatment, and it
Hmm.
helps them pursue treatment with a therapist and make sure they get good care from the beginning.
Okay. Excellent. Okay. So there is they do kind of admonish them to use a therapist at some point, if necessary.
Yeah, I think it would be irresponsible to think that somebody with significant anxiety could just read a book. I mean, a very important part of what we do is teaching people here's how an anxiety disorder works and here's how we treat it. And then the second part is exposure is sort of weird, so helping them learn how to do it. But then the third piece is it's just hard, and they just need someone who's confident because they've done it time and time again that helps steers them through and helps them be successful. And there's probably there's no replacement for a seasoned therapist or an expert helping you through the process. So it's probably not realistic that you could just do it with a book.
Well, with that in mind, with that, I mean, thank you for not putting me out of business or yourself out of business. um, uh, with that in mind, I know that technology is something that you've been utilizing more at the clinic. How are you doing that? And obviously, I don't think you expect people to be put out of business for chat therapy or something. What kind of technology are you utilizing at the clinic to help people?
Yeah. So I've been working for a long time to try to figure out how to use technology to better deliver child mental health care. Um, and I think probably I have sort of an old school, antiquated view of how to use technology, and that is basically just to support people doing therapy, support people helping kids,
Mhm.
rather than replacing. And so I think I see the way we've been trying to develop it is that technology is most helpful for delivering information or exchanging information. So there is a good evidence base on what is the best way to approach anxiety disorders and OCD. Exposure.
Right.
Here's how you
Yeah.
do exposure. Most
Mhm.
people don't know that. Lay people don't know that. Many, generalist therapists don't have an expertise in that. So how do we give that information to everybody? Kids themselves, family members, pediatricians who are the main people that families see when they have mental health concerns, uh, uh, generalists, health providers, or mental health providers. How do we give them the expertise to get as close as possible to evidence-based care? And then also, how do we gather the information from the family? So we need to know, what are you afraid of? How do you avoid? Um, and so we gather information from them. So I see technology as a way to make it easier for us to explain, here's what you need to do, for the patient to explain, here's what bothers me, and put together a treatment plan. And then the second piece is that empowers families to do as much as possible without us
Mhm.
so that we can see more people and it's less burdensome for them to work with a therapist.
Gotcha. Okay.
But as I mentioned, I don't think technology can replace working with somebody because fundamentally you just need somebody who's warm and expert and knowledgeable and calm to say, you need to do this and I'm going to help you do it.
Okay. Yeah. Somebody coaching, or somebody guiding them in the process, a Virgil to their Dante. Yeah. Yeah. Uh, so that, with that being said, I assume you mentioned videos for exposure, for instance, to dogs.
Yeah.
Is that
Mhm.
something that, like, do you have an array of videos available uh, through your website, through the clinic, so that people can like go through and use them, or do you suggest them to people, or how do you do
Yeah.
that?
That is a great question. And it's really a funny question because I did like what we're doing right now is like an amazing technological advance. And I don't even think of it as technology. I mean, talking to someone through video conferencing, that's not technology. That's just something you do, watching
Right.
videos
Yeah.
on
Yeah.
YouTube.
Right.
Not technology. That's just the way things are,
Yeah.
So that's a great perspective that we use technology all the time and it like don't even really think about it anymore because it just becomes so ingrained in daily life. Um, but so uh, we rely, yeah, so we use the most frequent way we use videos is for kids who are afraid of throwing up. And so hearing sounds, seeing people be sick, seeing people throw up makes them very nervous that they will then throw up. So those are the most often videos that we use, and we use websites that are there are websites out there who have accumulated those videos in a therapeutic
I was going to
context.
say this isn't like TikTok videos of
No,
somebody
no,
on a
yeah. Now,
New Year's Eve
sometimes we
party.
will have parents on their own go to YouTube and just look up vomit videos. But there's this great website that we use um, that has it's got a lot of information, including probably around 20 videos from super easy cartoonish things to disgusting videos of adults throwing up.
Okay. Well,
So
that's nothing I ever searched for, so it doesn't come up on my YouTube feed. But it does sound kind of slightly entertaining. I'm not disgusted. I actually have the opposite reaction. I usually laugh. So
yes,
it's a
some of
good
them are
laugh.
very
Yeah. Yeah.
some of them are very entertaining. But that also that is another advantage of working with parents. Is that sometimes when doing exposures, you do things oftentimes that kids don't normally do. Kids do not normally watch videos of people throwing up or go around and touch public surfaces a lot or go up to, people at stores and start conversations or return something. So we ask kids to do things or like repeat upsetting thoughts that make them
Right.
nervous. And one of the advantages of working with parents and having the parents set up and do the exposures with them is that we're vetting everything that we do so that the family feels comfortable with it. We don't ever do something that the parents don't feel comfortable having their child do. And if they do have reservations, we talk about it beforehand. And if we can talk through it and decide, yep, this is what needs to happen, we do. And if we say, this is not consistent with our family's preferences and values, then we find another way to approach facing the fear.
Okay. Excellent. And kind of staying on the topic of the clinic, have you, like, with regards to this particular model, have you tested this against treatment as usual and just normal exposure without the parents versus having them in as a cohort or a confidant?
Thank you for asking that question. That's a great one. So we have, yes, so we have one, what I think is well done controlled trial that we completed. We began in 2020 and we wrapped up in 2022, and we are in the process of revising and submitting the first manuscript for that, and we have some papers coming out of it. We did a study where we compared our parent coach exposure therapy to the traditional cognitive behavioral therapy that has been used in the majority of research on childhood anxiety treatment, including the biggest, most comprehensive studies.
Mm-hmm.
So all the therapy was individual, one therapist working with their child and parents. And in our parent coach exposure therapy, the therapist worked with the parents and the child together and educated them and made a plan through sessions 1 and 2, began exposures in sessions 2 or 3, and then did parent coach exposures in the session with homework to do exposures between sessions for as long as needed until they were better. In the other condition, therapists worked with the child individually for the most part. Parents began in the session at the beginning and at the end, kind of getting updates and about how things were going.
Mm-hmm.
For the first 6 sessions, the therapist taught the child how to recognize anxiety and to relax and do cognitive restructuring and make a plan to handle anxiety. And then the second 6 sessions, they began doing exposure.
Mm-hmm. Okay.
And what we found is that the kids who had parent coach exposure therapy were much better in the middle of therapy after 6 sessions because they'd been doing exposure. They were much better than the kids who had the traditional CBT. And then even at the end of the study, when both of them had the opportunity to have some exposure, the kids who got parent coach exposure were still a little bit better, had improved more than the kids who had CBT. And on top of that, the kids in the parent coach exposure therapy had attended fewer appointments than the ones who had CBT. So that best study that we did suggests that our treatment is more efficient and effective than traditional CBT.
Were there any follow-ups, 6 months, a year, anything like that? Has that happened?
No, we haven't done that. So this was just the first study that we did. We are planning to do a chart review follow-up, kind of through the medical record, see kind of what's happened to them afterwards.
Okay.
Yeah.
Yeah. Okay. I mean, usually if it's continuing, it's going to manifest in other issues. So yeah. Um, okay. Okay. How do you do you ever have like it's never really clean, probably in clinics or hospitals, certainly not in outpatient therapy, but do you ever see comorbidities and how do you parse them out? And do you and how much of that might be primarily affected by anxiety or OCD?
Yeah, yeah, that's a great question because nobody falls into the nice, neat, clean boxes of diagnoses that we have to work from. So the first part about comorbidity is kids often have more than one anxiety disorder or anxiety and OCD. And so that's easy to deal with because for all anxiety disorders and OCD, the treatment is exposure. So we can lump those together as one thing that we work on. The second piece is there are some of the most common comorbidities that we see are uh, anger outbursts and lack of cooperation, uh, depression, feeling sad and down. We often see a lot of eating issues. Um, so restricted eating, having lost some weight, and then also social communication difficulties, autism spectrum problems, kids who have difficulty understanding social cues, difficulty interacting with others. Um, yeah, and also being in a medical center, we also see a lot of kids who have they have chronic pain or they have other medical issues that they're dealing with.
Okay, which may or may not be a somaticization from
Right.
the anxiety and the other things. Okay,
Yeah.
yeah,
Yep. And so when deciding on what we need to treat, the first question is what is most distressing and causing most problems for the child? And so we look to them and we don't expect them to answer it on their own, but they are the expert on their experience and their parents have more expertise about their child than we do. So we work together to take their experience and our understanding of mental health issues and come together with a priority. What is the main thing that's causing problems? And then we work on that. And if it's an anxiety disorder, but there's other comorbidities, we then decide, is there anything that's going to stop us from doing exposures? So if a child gets angry and is oppositional, we probably need to work on that first before we do exposure therapy,
okay,
even if they are only angry and oppositional when they're anxious. But when they get anxious, they are just, they throw such a fit and they're so uncooperative. We need to use behavior management, rewards, and consequences to get them to be more cooperative before we can be successful with exposure therapy.
okay. And so you will definitely take a child with those issues,
Yeah.
work on shaping the behavior that
Yep.
way, and then yeah,
Yep.
which is
Yeah, and kids can have more than one problem. Some kids are just generally oppositional and stubborn and have big emotions, but they also have an anxiety disorder. And again, we may say, look, we got to get the general cooperation. If they're not cooperating with doing their homework, they're not going to cooperate with facing their fears. Let's address the cooperation first, even though we know the anxiety is the bigger problem. We can't successfully work on that until we get cooperation.
gotcha. Yeah,
Uh,
well, you're also kind of setting up a yes set for the cooperation. Like, oh, we'll do
Yeah.
this, I'll do that. The next one gets easier.
Yep.
Yeah.
And behavior management is also like a general part of our treatment from the beginning. We call it the motivation plan. So how facing your fears is difficult. So how do you stay motivated? You take small steps rather than requiring big steps. A lot of parental warmth and attention for brave behavior and removing attention for anxious behavior, setting goals and rewarding progress and mild consequences for not completing exposure. So that those general principles are integrated into our approach from the beginning.
Are the behavior management issues also attended to with the parent involved in it?
Yes, yeah, even more so with behavior management, especially with younger kids. With behavior management, we're focusing mostly on working with the parents, helping them put into place a plan that they can use day in and day out at home to change their child's behavior.
And just so we can offer it to the audience out there, how are our behavior management issues involved in the book, and how might they be as a predecessor or a precursor to the exposure therapy? Are they at all addressed much in the book?
So we talk about lack of cooperation and anger outbursts, and when that's severe and persistent, qualifying for a diagnosis of oppositional defiant disorder. We talk about that in the first section of the book when we talk about differential diagnoses.
Yeah.
We talk about the motivation plan in the second section of small steps and attention and rewards and consequences. And then in the end of the second section, when we talk about problem solving, troubleshooting, if things are not working well or if the other things getting in the way, kind of what to look for, we revisit behavior management there as well.
Okay.
But mostly if behavior problems are the main thing, then we need to do that before we do this book. And here are some directions on finding help for that.
So resources. Yeah. I was going to say smart. Okay. Well, book is wonderful. Is it available now?
It will be coming out shortly this year, so it's not available yet.
Okay. So in the next couple of months. Okay. But I've had the luck of actually reading it ahead of time. Yeah. So
good.
I've had the review copy. Yeah. And it is the anxiety coach, right? A Parent's Guide to Treating Childhood Anxiety and OCD. And it's from the Mayo Clinic itself.
It is. So I work at Mayo Clinic, and it's put out by Mayo Clinic Press.
Okay, excellent. And can people reach you, Dr. Whiteside, on the internet if they're interested in contacting you for clinical work or consultations?
Yes. Dr. Stephen Whiteside at Mayo Clinic will bring up a couple different official Mayo Clinic websites. I also would mention that we have a resource, Mayo Clinic Anxiety Coach.org, that presents all the kind of the general education aspects of our treatment for anxiety, and a library for building fear ladders, some descriptions of exposure. It also has a description of our behavior management program, and that's a freely available website.
Excellent. Well, thank you so much. It has been a pleasure speaking to you today. Hope to have you back sometime soon.
That was great. Thank you so much.
Thank you for listening. Did you know the Psychology Talk podcast is all over the World Wide Web? Well, not entirely all over, but we are on social media and we do have a website. Pop over to www.psych-talk.com to find out more about the show. All material is copyright the Psychology Talk podcast. Opinions of our guests are not necessarily those of the host or the show. Material is provided for entertainment and informative purposes only. If you need a mental health professional, please seek one out. Music is provided by the band Serenati.